Good afternoon. I must be a sucker for punishment, because why would I put myself after two such excellent speakers? But here we go. I was thinking about what I was going to say, and then of course I thought about when we say cross-cultural, what we are trying to talk about is tropical issues very often. What's so different about the tropics? And of course we're also talking about what's transcultural. And I'm going to just highlight some factors in neuropsychiatry, both the neurobehavioral syndromes and the psychogenic syndromes, which are of interest in the part of the world that we live in. When we say neuropsychiatry, we're looking at obviously the interface between neurological symptoms and signs and psychiatric symptoms and signs. Believe me, there are psychiatric signs as well as symptoms. They're less well documented than neurological signs. So what's tropical about it? The first, that it occurs in the tropics. That's probably what is tropical about it. That it describes neuropsychiatric manifestations of diseases that are more prevalent in the tropics. That's probably true. That neuropsychiatric diseases have unique clinical manifestations in the tropics. Probably true. That neuropsychiatric diseases have unique psychosocial implications. And in one way in which we can think about a lot of what we are talking today is, are there different causes? Are there different manifestations? Are there different consequences for the different disorders that we are thinking about and talking about across cultures? Now, what's specific to tropical countries is it's not just geographical, the tropical zone, or the climate, which is warm and wet. There are socioeconomic issues, malnutrition, poverty, overpopulation. These are issues. There are cultural attitudes to neurological and psychiatric disorders. And there are genetic factors. For example, we see true differences in multiple sclerosis prevalence between tropical and temperate regions of the world. Why are neuropsychiatric manifestations important? They increase morbidity and mortality. They certainly have an impact on quality of life. They certainly complicate the treatment of the condition. They certainly do lead to compliance issues, people sticking or adhering to treatment. They certainly make diagnosis more difficult in a number of situations. And of course, they do have many sociological implications. Those of us who work with epilepsy are familiar with the stigma that goes with the condition. Those who work with dementia are familiar with the stigma that goes with the behavioral and psychological symptoms of the condition. So in a sense, therefore, there are a number of implications that we ought to be concerned about. So we have both semiology and causation factors, seizures, non-epileptic seizures, affective somatoform symptoms, which we'll talk about briefly, psychotic symptoms, catatonia, delirium. We see all this as syndromes. And of course, we see hysteria, we see somatization. In Southeast Asia, we see running amok, which is a form of episodic dyscontrol, which we'll talk about. And we do see some interesting acronym syndromes, which are typical to this part of the world, when we start caring for people with various forms of disability, which I'll just talk about as well. One important cause, and I'm quite surprised we've not brought it up yet, because in all Indian meetings it comes up quite early, is what we see as psychosis and infectious diseases. And infectious diseases do have fairly unique neuropsychiatric manifestations. And of course, they are more prevalent in the tropics. Here's somebody whose brain is studded with cysticerci, and psychiatric symptoms can be the manifesting symptom of neurocysticercosis in as many as 65% of neurological outpatients. This is what has been shown. Depression, quasi-psychotic symptoms, not typical of schizophrenia, confusional states, these are quite common manifestations. We've seen our share of patients with cysticercosis here who do present with neuropsychiatric manifestations. And of course, psychiatric morbidity is associated with active infestation, It's associated with intracranial hypertension, and of course it's associated with pre-morbid history of having had similar symptoms before the infection manifested. Herpes simplex is something that we see quite frequently, and we did discuss a patient this morning where that was considered as one of the differential diagnoses. Patients present with fever and headache, they have generalized tonic-clonic seizures, but they often have confusion, disorientation, and memory deficits, with very clear temporal lobe being disproportionately affected, as you can see in the picture, with the very extensive hyperintensities in the bilateral temporal lobes. And of course, in the neuropsychiatric sequelae are a chronic post-infectious state with temporal encephalomalacia, frontotemporal gliosis. People tend to be emotional, irritable, anxious, depressed. They have left prefrontal hypoperfusion, which persists. They do have long-term memory deficits, which are associated with amygdalo-hippocampal atrophy and sclerosis. They continue to have seizures, and of course, they can develop, with the destruction of the bilateral temporal lobes, the lobe abusi syndrome, which is a very typical manifestation of bilateral temporal lobe damage. The other thing that we see in abundance are vitamin deficiencies. Most vitamin deficiencies, B1, B3, B6, and B12, all cause neuropsychiatric symptoms. Confusion, irritability, depression. These are symptoms that we see very often with vitamin deficiencies. CMC Vello has reported depression, which is associated with subacute combined degeneration of the seen in the spinal MRI. We do, of course, also have patients who come to us with red herring presentations. There was this cab driver who was brought into clinic one day, and he had just witnessed an accident 24 hours ago. And in the 24 hours that followed, he was found to be confused and disoriented. And in reality, when we examined him, when I examined him, he had bilateral papilledema, and he actually had Japanese B encephalitis that was undiagnosed. It was attributed to his having witnessed an accident. And unfortunately for him, he lived for about 10 days and then succumbed to the illness. So that is one case. We have had a migrant worker who presented with herpes simplex encephalitis, but that was again attributed to the breakup of his marriage, and he did not receive treatment for some time. Luckily for him, he did actually respond well to treatment. Most interesting patient we've had also is a gentleman who had a discussion with a nephew about property, and at the end, that discussion didn't go very well, and the nephew threw the food which they were eating across the room onto the wall behind his uncle. And this incident so upset him that he was found to be confused, disoriented, and suffering from memory loss thereafter. Interestingly, this wasn't a hysterical manifestation. He actually did go on to develop fairly profound dementia. He remained under our care for about 7 years, and he never recovered from that incident. And pre-morbidly, until the day before, he had been going to the bank, he had been dealing with his usual activities, and there was no suspicion of the man being demented at all. So we do see unusual manifestations in this part of the world, which are related to and unusual attributions as well. Running amok is something that's been reported widely from Southeast Asia, and various forms of running amok have been talked about. Mengamuk is making a furious and desperate charge. Baramuk is a personal loss and sadness, and its amok follows rage or perceived insult or vendetta. The person often acts irrationally. There is homicidal and suicidal behavior. There may or may not be a previous psychiatric history, but it's thought to be a syndrome of episodic dyscontrol. DSM-4 calls it a culture-bound syndrome seen in primitive societies, which is rare today. And it's been commented that it's not the running amok itself which is culture bound, it is the way in which the person runs amok, which may be. So the manifestations and the the weapons used and so on are what the culture determines. It could be a feature of depression, psychosis. It could be a feature of a dissociative or a hysterical disorder, and it could be a feature of a personality disorder. Of course, it's a very common medico-legal problem because episodic dyscontrol often comes up in medico-legal situations. The person says, I have no memory of this, and I was not in control of myself, and therefore I cannot be held responsible for what I did at that time. And that is, of course, a very difficult and contentious argument which one can have till the cows come home. Catatonia, of course, the syndrome of Carl Baum, is a syndrome that is seen less commonly now in the West. It still remains reasonably common in the tropics. What I'd like to point out is that the causes of catatonia are very much more medical than psychiatric. There is a belief that depression and psychosis causes catatonia. The smaller proportion of catatonia is caused by depression and psychosis. Infections, metabolic syndromes, all of these can cause catatonia, and since we have a high prevalence of those in the tropics, we do tend to see those causes. We've seen typhoid causing catatonia, for example, and we've seen a number of other infections and metabolic conditions cause catatonia, including Japanese bee, tuberculous meningitis, cerebral malaria, and a host of other syndromes. Another thing which was described in the West in the previous, not in the last century, the century before last, was group hysteria. It continues to be reported in non-Western cultures, and when two or more healthy people start to share similar beliefs and symptoms. It often happens in school children, it often happens in co-workers. It's usually a mass response to some kind of concern or fear that people develop. In India, we do see this as part of religious rituals, and you can see various manifestations of it. For example, in temples, there are people who have very similar symptoms, all manifesting together. And of course, reports like this, which talks about a large number of school children having developed group hysteria, still tend to keep coming out in non-Western cultures. Just to very briefly allude to the spectrum of non-organic neurology, you have hysterical syndromes and somatoform syndromes at one end of the spectrum. Here the idea is that there is no conscious awareness of what is happening. The person is not aware that they are manifesting a symptom for a psychogenic reason. On the other hand, there are what we call factitious disorder symptoms, and factitious disorder is the condition where the person is addicted to the hospital environment, is very much more comfortable in the hospital environment, and tends to repeatedly seek consultations and reassurance and manifest with different symptoms. One famous story related to factitious disorder is that of the Munchausen syndrome, the Baron von Munchausen story. And then, of course, there is overt malingering, which is for gain. The person knows that they are putting on the symptoms and they have a very specific purpose in doing so, like avoiding going to court or avoiding being in prison and things like that. So all three are manifestations of non-organic neurological states. Now, there was a very famous paper by Elliot Slater which reviewed the diagnosis of hysteria at Queen Square, the mecca of neurology. And 10 years on, when he looked at a lot of people who had been diagnosed as having hysteria, he found that the diagnosis was wrong 90% of the time. And this paper really put the fear of God into a lot of people, because it meant that even very eminent neurologists were turning away patients as hysterical when in fact they went on to develop an organic cause which explained their symptoms. The paper was revisited about 10 years ago, once again in the National Hospital, and mercifully what they did find was with modern technology, the misdiagnosis of hysteria came down to 10%. So we were getting it right very much more often now than we were getting it right previously. And of course, people therefore can have organic causes that are undetected, manifesting as hysteria. We heard the very good examples of migraine, for example, where there are manifestations which could be thought about as completely psychogenic. There are psychiatric disorders like depression, which present with physical symptoms, abnormal illness behavior, the preference for the sick role that we talked about, Munchausen, and of course, overt gain or malingering. What we see here are also unique cultural attributions to illness. So we have this 45-year-old university graduate, fairly well-educated person working for a multinational company, drawing a decent income, living in Chennai, and he had a very peculiar symptom. He would climb the steps to the railway station where he lived, and as he reached the top step, he would become breathless, he would collapse briefly, and he would have jerks of his limbs. So he was thought to have possibly seizures, he was thought to have some kind of a cardiorespiratory syndrome. He was widely investigated before he came to us. When he came to us, we spent a lot of time talking to him. And what we found was that he had multiple autonomic symptoms which seemed to be triggered off by this act of climbing the stairs. And when we went deeper into this, we found that he had lived in the same area for a very long period of time, had become prosperous and built a 3-story house, which was much more than most of his relatives and friends and neighbors had achieved. And he had been told that black magic is being practiced on you because people are very upset by your success. And these thoughts would preoccupy him, especially when he left his home and went to work every morning. And basically, with management of anxiety, with cognitive behavior therapy, with rationalizing those thoughts, he actually managed to get over these symptoms. And he did not have any decompensation, either cardiac or respiratory, that would explain the symptoms, nor did he have seizures or any variant of seizures. So cultural attributions to symptoms are something, or cultural causes are obviously very important when we start talking about psychogenic syndromes. This is another person I've presented frequently. I've shown this video, and we're still looking for advice here because we haven't really identified what it is that the person has. But this is a 20-year-old girl in her second year of university. She was living at home with her mother. Her father had deserted the family, and they were in strained financial circumstances. She was diagnosed to have epilepsy in adolescence. She had a history of staring episodes and generalized seizures, which were reasonably well controlled. She came to hospital with a 6-month history of significant worsening of seizures. Frequent generalization was described, and by the time she came to us, she had gone on to polypharmacy with little effect. There was no improvement in her seizure control. When we went into the history, we found that her sister had got married, and for dowry reasons, was sent back to her parental home, and she actually had committed suicide. And this young lady had left her sister at home alone, gone to college, and when she came back, she was the first person to see her sister hanging from the ceiling fan. So it's a fairly traumatic, extremely upsetting experience that she had had, and her worsening of symptoms coincided with that experience. Now, we would probably think of it as a standard, seizure episode, but I'm going to try and get this video going.
Yeah.
This was the day before we had video EEG. So she's having a video taken and an 8-channel EEG running side by side. So she had these movements of her feet, and then she had these very unusual movements of the face.
ரொம்ப டென்ஷன் எமோஷனாக உண்டு,
which we think are very hard to mimic.
கை கீழே வச்சுக்கோமா,
மருந்து தான் நான் சொன்னா தானே போட்டுக்கிறேன். உன் பேர் சொல்லி பார்க்கலாம். என்னெல்லாம் மருந்து போட்டுக்க தெரியுமா? என்னெல்லாம் சொல்லு.
Morning too.
So she starts talking, and the movements, which appear to be terribly involuntary, stop. And I'd like an opinion from our experts as to what these movements may be.
Wow, I agree. It looks like it would be very difficult to do voluntarily. One question, on repeated episodes, would she break with speech? Or, because it looked like there, I didn't quite understand what was being said to her. It sounded like there was a delay, and then she was able to start.
So she has this cluster of involuntary movements, which, I mean, the best description I've heard is myokymia. And then she's asked a question, what drugs are you taking for your epilepsy? And then she starts naming the drugs. And when she starts naming the drugs, she stops having the involuntary movement. And there was a delay in starting to name the drug, but I don't think it was because she was confused or disoriented. It is more because, and of course she had those movements of her feet as well, simultaneously.
I think the foot movement looks more voluntary, potentially. It doesn't look as quick. The interesting thing, when we get to her lips, it looks like to me, and appreciate your thought, it looks like there's a very rapid component to this that's almost rhythmic. And I don't know.
That's a good orofacial movement. I'm not sure I can duplicate it, but it strikes me as very unusual for any kind of automatism, for example, or repetitive focal seizure activity involving her orofacial musculature. So, you'd like to know what her EG showed during this and so on, but my suspicion would be that this is not epileptic or physically based.
So the EEG, which was running side by side, was completely normal right through this episode. There's no change on EEG at all. She had a good alpha rhythm right through. And without too much of drug change, actually by treating her for her psychogenic causes, we got her a lot better. And we concluded, therefore, that the worsening of seizures was probably a mixture of both non-epileptic and epileptic seizures, with the epileptic seizures remaining fairly well controlled, but the non-epileptic seizures being very profound given the circumstances. But once again, the cultural causation is what I wanted to highlight, a profound psychological event in the family resulting in a breakdown of seizure control. Then this has been talked about, there is much talk about somatization in non-Western cultures, and somatization and somatic attribution is having physical symptoms with actual psychological or psychogenic causes. And there have been a number of studies which have shown that people from non-Western cultures, for example, Indian and South Asian people living in Great Britain, tend to manifest physical symptoms more rather than psychological symptoms. And they tend to amplify their symptoms, and they tend to attribute to these symptoms. So rather than say that I'm depressed, I say that I'm feeling tired, I have pain, So there's amplification of the symptoms, and then there is attribution of the symptoms. And this is something that we see a lot of in our practice. In fact, if one works in a large public hospital in India, and certainly this part of India in Tamil Nadu, we talk about the KKK syndrome, which is the Kai Kal Kodachal syndrome, which means that the person comes and tells you that, oh, my Kai Kal ella kodedu, which means my hands and legs are all aching. And that is a very typical presentation of somatization in our culture. The other thing that attribution to black magic, spirits, role of native and faith healers, these are very common in these in non-Western cultures. And what is also interesting is that these patients have been found to acquire psychological models as they go through the care process. So they come believing that this is all somatic, with somatic amplification and somatic attribution. But as they go through therapy, they actually discover the psychological causation to these symptoms. So this is what the man who collapsed on the steps said, that I've been quite successful. I built a 3-story house. My relatives are jealous of me, and I think that they may have cast an evil eye or performed some black magic, which is why I'm collapsing and having these episodes. So I've talked about somatization and somatic attribution. In managing neuropsychiatric disorders, we see some interesting acronyms. So one is the Parents in India, Children Abroad syndrome. I had a call from an Indian origin oncologist, very eminent person working in the US and living in the US. And he called me one day to say, some years ago, to say, can you go to my parents' home and see my mother? I think she's developing dementia and I'm very concerned about her. And he said, oh, they live in a garden flat. I've got 3 people looking after them round the clock, and it's all hunky-dory, but she's losing her memory. And when I went there, sadly, I could smell the urine from the front gate. So that was the level of care that these 3 people who were being paid to care for were delivering. There was no family member to provide a coherent history or give us a proper sort of chart of what medications these people were on or what the problems were. The lady was nearly 90 years old and was in moderate dementia. The husband was 95 and completely blind. Now, this is not an unusual Indian story today. We have many patients where the parents are here, they live in splendid isolation, they actually have a lot of money coming to them from the children who are working abroad and living abroad, but there is no one to actually provide care. And so hence the emphasis on the PICA syndrome. We see the opposite with young children with attention deficit hyperactivity or various neurodevelopmental disabilities, where there is no parental attention to them when, for most part of the day, because both parents are at work, they're usually under the care of the maid, and there is no one paying attention to them. So the child at home, parents at work is something that we see a lot of as well. And because of the lack of social support systems very often, the implications of having illness are very, very different, therefore, in our culture. Just to quote the Mental Wealth of Nations paper, which was published in Nature in 2008, and where it said that countries must learn to capitalize on their citizens' cognitive resources if they are to prosper both economically and socially, and that early interventions for emotional health and cognition will be the key to prosperity. And this is probably quite true, both when we look at the children with developmental disability and when we look at older people who are beginning to lose their cognitive abilities early on in life and are not able to take care of themselves. And there is a need for cross-cultural focus. So we work here with a team approach. We have many members of the team taking part in the patient's care, and we believe that a multidisciplinary model of care is what will work for the vast majority of these more complex syndromes. And this is our typical workflow. A patient reports to the clinic, they are triaged by the physician, they are seen by the whole team, The physician then reviews the reports, also the lab reports and imaging reports, and then a treatment plan is put in place. And we believe that continuous counseling and advocacy are something that patients with a vast majority of neurological conditions and mental health conditions need. For example, many people don't know what disability entitlements that they should be getting. Many people have no idea how they should be seeking appropriate care or benefits. And if the healthcare system can't give them that information, they are never going to get it. So that is something that we feel is very, very important. So in terms of causes, therefore, we do have unique infectious, inflammatory, and psychosocial causation for symptoms. And I thought we should highlight that. In terms of manifestations, we do see very atypical manifestations. Amok, for example, is a good example of a culture-bound syndrome that may have biological causation, which has never been properly investigated. And then, of course, in terms of consequences, the consequences that we see of illness in this culture are very different from what is seen in Western cultures. And they too need focus, because in terms of public health, a public health vision, I think being able to prevent causation, but also being able to tackle the consequences is both very, very important in terms of being able to prevent disability. And I think that's one of the reasons why a cross-cultural dialogue or discussion is actually necessary. So there is a rich interface between both neurology and psychiatry in the topics. In the tropics, it is an important cause of misdiagnosis, inappropriate treatment, and of long-term disability. A lot of the work that we do is poorly documented and poorly published, and I think we have no one to blame but ourselves, because we get so preoccupied with looking after patients that we are not able to or willing to, in a number of instances, put down what we are seeing. There is a unique opportunity for Indian scientists to lead on, and we do have an interdisciplinary PhD program in VHS. Dr. Subbulakshmi, we're very happy to talk to people about that if people are interested. This was our first book on cross-cultural issues in dementia, and I'm very happy that the next one is on epilepsy, and it's about 90% complete, so we hope to see it come out this year. Thank you so much.